Much, Chairperson, and thank you once again for inviting me to deliver this talk, and thank you for organizing this as well. So, a very good afternoon to all the distinguished guests, so participants. I realize that this is a very good afternoon because the sun is still nice. So I will just keep this simple and short. Post-op nausea vomiting in daycare surgical procedures. I have no conflict of interest to declare, and just before I start, I would like to just tell a story about one of my colleagues. So I have a senior MO actually working under me last time. So one day he was telling me, Dr. Ken, last time he had this lab quality procedure, so he went to private and do. So after the operation, he said, oh, there's totally no pain, pain-free. But he had a very terrible post-op nausea vomiting. And he told me that if he were to do that again, he would rather choose to have the pain than post-op nausea vomiting because it's actually very distressing. So the story is that if you do not remember any of whatever I'm telling you, just remember that post-op nausea vomiting is actually very distressing to patients. So do manage this properly. Most of the content I'll be taking from this consensus by Professor T.J. Gan. And Professor T.J. Gan is actually a Malaysian, but he actually left to US and he's actually doing great there. On and off, he'll be coming back for exams. And for introduction, nausea and vomiting are actually the two most common adverse events in post-operative period. And it's about 30% in general surgical population and up to 80% in high-risk cohort patient. So how do we actually define them? Nausea is actually defined as an unpleasing sensation causing discomfort in the stomach area, which gives the feeling of impending need to vomit or retch. It's actually a transient sensation which is frequently followed by active retching or tachycardia and increased dilation. Vomiting, whereas, is the involuntary forceful expulsion of the content of the stomach through the mouth or nose. And there are actually few phases of emesis. First, you start off with a prodrome, and then there will be retching, there will be increase in all this intra-abdominal pressure, and then reduce in thoracic pressure, and subsequently they expel out. So how does this happen? There are actually four sensory triggers. There's four sensory pathways that trigger the emetic effect. So first is the GI vagal afferent. So that's why patients who actually undergo laparoscopic operation or they actually all this bowel surgery have a higher predisposition. The other one is area proxima for detection of circulating toxins, and subsequently vestibular complex for motion sickness. So that's why patients who has all this ear surgery, they are at higher risk as well, especially if they actually manage the cochlea. And of course, forebrain descending pathway for cognitive and learn response. So these are the chemokines that are actually involved in all this post-op nausea vomiting. They have all this serotonin, histamine, muscarinic, dopamine, and also substance P. And how do we actually define post-op nausea vomiting? It's actually nausea or vomiting that occur in the recovery or baku during the first 24 to 48 hours after surgery. And PDNV is actually post-discharge nausea vomiting. Means in patient come from daycare, they actually discharge back home. So it's actually about 17% for nausea and also 8% for vomiting. And this is actually a chart simplifying how we actually define them. Post-op nausea vomiting is, starts after the emergence, post-discharge nausea vomiting after they discharge back home. And for prophylaxis, it's actually given between pre-op to surgery itself before the emergence. Okay, why is this important? It's actually important for a few reasons. For the patient, causes dehydration, electrolyte imbalance, acid-base imbalance, they actually cause pulmonary aspiration. If the expulsion is too forceful, then it might actually cause pneumothorax, esophageal rupture, increase in ICP, and also delay resumption of oral intake. But how does it affect the surgical site? It can also cause suture rupture, wound dehiscence, also bleeding in extreme cases. And to hospital administration, actually causes longer stay in hospital recovery, unanticipated hospital admission or readmission, increased healthcare costs, and subsequently dissatisfaction with surgical experience. Of course, our surgeon did a very good job, but if patient got nausea, vomiting, they will think, why do they have all this kind of like side effect? You know who to blame? Nurse or surgeon, I'm sure, or the overall experience. So therefore, it actually makes a lot of sense to actually give them post-op nausea vomiting prophylaxis. The choice of antiemetic will actually depend on clinical context, and we always need to balance between the risk of adverse effect, cost effectiveness, because all these drugs are actually expensive, drug availability, drug formulary, whether is it available in our KKM or in wherever you are practicing. And subsequently, the post-op nausea vomiting prophylaxis should be implemented based on patients and also procedural risk factor. So Prof. DJ Gan and his team actually outlined a few measures. First is to actually identify the patient's risk, and then subsequently reduce their baseline risk for post-op nausea vomiting. Administer the prophylaxis using 2 interventions in adult at risk, or combination of prophylactic antiemetic to children of increased risk. And for those patients who did not have any post-op nausea vomiting prophylaxis, and if they vomit or when the prophylaxis actually failed, so we should actually promptly treat with antiemetic. And number 5 is actually to ensure multimodal post-op nausea vomiting prevention and also timely rescue. And number 6, if the patient is in an enhanced recovery pathway, to administer multimodal prophylaxis antiemetic. So we are talking about a lot of risk factors. Of course, all these risk factors need to be addressed because we need to re-stratify for cost effectiveness. So whatever that we know now is for positive overall, female sex, history of post-op nausea vomiting or motion sickness, non-smoking, younger age, or GA, they actually have higher risk of post-op nausea vomiting, as well as being given post-operative opioid, duration of anesthesia, or the types of surgery as well. Other conflicting evidence are like ASA physical classification, menstrual cycle, and also anesthesiologist experience and fasting. The other one that actually has been disproven are BMI, anxiety, NG tube, migraine, and supplemental oxygen. So we actually address all these risk factors one by one, and how we classify them so that we can remember easily is we classify them according to patient-related, anesthetic-related, or surgical-related. Actually, put on the OR there is a odds ratio. So we can actually see that for female gender, it's about 2.5 times. PONV is about 2 times. Non-smoking status also 2 times. And then age also affect as well, up to 2 times for post-discharge nausea vomiting. As well as anesthetic-related factor, for patients who actually undergo general anesthesia, they have actually higher incidence. And if there's a prolonged duration of anesthesia as well, if the usage of volatile agents are being used, then they will have a higher risk of post-op nausea vomiting as well. And nitrous oxide, so as well as intraoperative and post-operative opioid analgesic. And one more thing is, if there's a use of neostigmine more than 3 milligrams, they are also have increased risk factors as well. But as for surgical related, it's usually about those extended surgical procedures or surgical categories like laparoscopic or even middle-ear surgery. Those are actually very complicated, right? So that's why we actually try to make life simple. We actually classify them using these FL criteria. So there are a few things just to that you can actually use to remember. First is, if this patient is female, non-smoker, has a history of post-op nausea vomiting, and given opioid, actually given a sum of a score of 1 each. And subsequently, their score actually correlates to the no risk factor with 10, 20, 40, 60, and 80. So it's actually very, very easy to remember. This is actually important, especially for master student taking anesthesia exam. So that's why we actually try to simplify all this graph. And as for post-discharge nausea vomiting, it's relatively the same, but we also ask whether if there's nausea in part 2 as well or not. And if there is, then it will be like, start off with 0, it will be 10%, 20, 30, 50, 60. So we try to make it easier to remember. But how about children? Because children are one of the main bulk of daycare surgery, right? So we categorize them into patient-related and also surgical-related as well. So if the child has a history of post-op nausea vomiting, or in PONV in relative, or more than 3 years, then they have a score of 1 each. And surgical-related will be either a strabismus surgery or duration of surgery more than 30 minutes. So they have a score of 1 each, and then they actually correspond to almost the same, 10, 30, 50, 70%. This is for post-discharge vomiting. So we'll see what kind of surgery are those, whether strabismus, tonsil leg, or dental surgery, and whether a patient has an intra-op or post-discharge opioid, and whether is it a long-acting opioid, and whether there's any pain and also presence of nausea vomiting. So all this is actually used to re-stratify the patients. So after re-stratifying the patients, what we can do is that try to bring down their baseline risk. Baseline risks are those things like try to avoid GA, use regional anesthesia, use propofol for induction, and also maintenance of anesthesia. Avoid nitrous oxide for surgeries more than an hour, and then we try to avoid volatile anesthetic. So this is the debate between the pros and cons of TIVA versus volatile anesthesia, right? And then subsequently, we try to minimize intra-op and also post-operative opioids. We actually promote multimodal analgesia, and we of course hydrate them adequately, and use of sugar Madex for reversal. This is a bit controversial because I'm also aware that sugar Madex is expensive, and therefore not many places will use it freely as well. Good news is that this is Prilocaine. Sure, now we are talking about this. B. Brown is actually bringing this in, so probably we're gonna be expecting Prilocaine in daycare surgery as well. Now I heard is that actually trying to register this, so hopefully it won't be long. And this is what I meant regarding propofol and also versus volatile anesthetic agent. So if you see here, right, volatile anesthetic, and with or without the presence of nitrous, they all have a higher risk of post-op nausea vomiting. But when we look at propofol and air, so their risk actually getting lower. So it's something to be considered on. So once we actually done risk stratification, whether they have 1 or 2 risk factor, or more than 2 risk factor, we actually give them appropriately, whether 2 agents or 3 to 4 agents. So for prophylaxis, what we can give is either serotonin receptor antagonist, antihistamine, propofol anesthesia, maybe acupuncture, corticosteroids, dopamine antagonists, or NK1 receptor or anticholinergics. It's actually for adult. But for children, also same, we re-stratify them, and then whether they are low risk, medium risk, or high risk. If low risk, we actually give none or just serotonin antagonist or DEXA. If medium risk, then it will be both. High risk, we'll actually have triple antiemetics. So how do we actually classify all these antiemetics? Basically, we just classify them based on their receptor mechanism of action, whether it's a D2 muscarinic, cholinergic, antihistamine, or serotonin antagonist or NK1 antagonist. So one of the most popular that we always use day in and day out, of course, is a serotonin receptor antagonist like ondansetron, granisetron, palanosatron. These are all first line for UNV prophylaxis, and usually we give at the end of surgery. I asterisk at the palanosatron because some guidelines actually suggest to give at the beginning of surgery. The reason being is that it's actually very long acting, so it doesn't really matter whether you give at the beginning or at the end, because your daycare surgery is probably about 1.5 hours the most. And like what I mentioned, if you can see palanosatron, the half-life is about 40 hours. But of course, cost is actually makes it that not many hospitals have it. But what we have in either KKM or University Hospital, we do have ondansetron and also granisetron. In my institution, we actually use a lot of granisetron because it lasts about 9 hours. So we can usually give it about 1 milligram TDS like that. And if you look at the number needed to treat, so for nausea and vomiting, we need to treat about either 4 to 6 patients in order to prevent one nausea vomiting if we are using ondansetron. So I think this is quite a very cost-effective measure. Dexamethasone as well is about 4 to 5 patients to prevent. We actually give 4 to 5 patients dexamethasone in order to prevent one episode of nausea vomiting. So I think all this is actually quite cost-effective. And what is the adverse effect? For serotonin antagonists will be like either headache, constipation, flushing, fatigue, malaise, but all these are usually quite bearable and less occurred. But the other prolonged QTC is something a bit sinister because sometimes they actually place reports about on this. And when we look at what if the 3 different serotonin antagonists, we notice that there's actually mild prolonged QTC for ondansetron. And then QTC is less pronounced for Rani, but so far there's actually no significant effects for Malano. So it's probably something to be considered about. And especially if you want to give serotonin antagonists for patients with no history of prolonged QTC, you might want to consider other modes of antiemetic. So, next drug is a corticosteroid. I like to give Dexa because I personally give Dexa a lot as well. For PONV prophylaxis, usually is about 4 to 8 milligram at induction, or for pediatric age group is 0.15 milligram per kilo. How it acts is according to its central inhibition of the prostaglandin synthesis. And how about other corticosteroids? Are they equivalent or similar efficacy? So far, other studies show that etapret is okay, but betamethasone has a smaller effect. Other than that, I just follow the steroid conversion dose if I want to have a similar efficacy. But so far, no issues. Antidopaminergics like amuse sulfide or metoclopramide. Metoclopramide is readily available in the ward, and we actually like to give them, especially when we are housebound last time as well. So how much do we give? Previous literature say that 10 milligram IV dose is actually not enough for prophylaxis. You need about 20. But subsequently, when they actually look back at the evidence, found that Fiji et al. Might have actually fabricated the studies because newer evidence noticed that 10 milligram IV does help. So actually up to our clinical experience as well. The number needed to treat is about 8 to 10, but it's actually not effective when used in combination. And the more we give, there might be a dose-dependent extrapyramidal symptoms. So especially be careful if you are giving more than 20 milligram TDS for quite a few days. Others like NK1 antagonists, Repitum, it's about half-life has a half-life of about 40 hours. It's available in oral and also IV. And oral will be about 40 milligram prior to induction. And it's actually more effective in reducing PONV rather than nausea. But we don't have much experience using this drug as well, more oncology side. So this is a summary for all the drugs. The drug name, the doses, and also the timing of administering them. It's all summarized here nicely by Professor T.J. Gunn. So, what can we give other than pharmacological methods? We can do a pericardium 6 acupuncture point. It's actually very easy. It's somewhere here. We actually press. or others that known as a NA1-6 also. It's actually same. Other than that, will be fluids. Make sure that patients are actually adequately hydrated. And that regarding carbohydrate loading, there's actually no impact on PONV. And others with not much significant difference are like music therapy. But aromatherapy only shown to reduce need for rescue antiemetics. So all these adjuncts are probably not that effective, except for TC6 and so fluids. These are the summary for antiemetics for children. And what if after giving all these antiemetics prophylaxis and then they fail? So then we actually have to give a treatment dose. It's actually indicated when PONV failed or when patients did not receive any PONV prophylaxis. So what the guideline actually suggests is to use antiemetic from different pharmacological class. So if actually patient was given serotonin antagonist, maybe it's time to use either dopamine antagonist. So if let's say 6 hours, we can actually use from different class. And if it's actually more than 6 hours, then we might actually consider administering antiemetic from the same class as well. So these are summary for the treatment dose. Do note that sometimes propofol can be used as well. So far in my experience, right, I only use propofol for 1 or 2 patients after failed all 3 antiemetics. Because my patients had DEXA, and they have granisetron and so metoclopramide. The patients still have very bad nausea, vomiting in recovery. But after I give propofol 20 milligram, patients actually stop. So it actually works quite well and wonders. So summary, what we need to do is that first we need to identify our patient's risk, reduce the baseline risk for PONV, and then administer multimodal prophylactic antiemetic for enhanced recovery pathway. I do consider that DAYCARE surgery is part of an enhanced recovery pathway because actually planning to discharge the patient on the same day itself, right? So, and cost effectiveness of giving 2 antiemetic for patients coming for DAYCARE, I think is actually worth it. And subsequently, we need to audit and also improve our local protocol as and when we see needed. Thank you very much.